Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
Okay. So I welcome one and all tonight for the OSCE part 2. This is a very, very important class. And see, I have a lot of mock questions of OSCE in my complete practical course. All right. But this class, OSCE, this is mostly the exam questions or the questions that you have been through in your different preparatory classes. All right, so some of the answers are already there with you, some of the answers I'll be discussing it tonight with you, and nevertheless it's going to give you a practice of the kind of OSCE questions that can be asked in your final DNB exam. Do not be scared of OSCE. Again and again I'm telling you, do not be scared of OSCE. This kind of preparation that we are doing right now in this class is sufficient for you to make you understand that how OSCE comes. You can never be fully prepared for OSCE ever. It only and only your proper theory will be able to guide you through, and of course a couple of practical things which will guide you through to OSCE. Otherwise it's not at all very difficult. I've seen so many questions which have been asked in OSCE. I mean, hundreds and hundreds of them. But what I have seen is that they are asking very simple questions, very, very simple questions, and you do not have to really worry. So now let's begin with the first question. So this, you just have to identify this figure. It's very, very simple. Everybody who's there in the class tonight, I think let's start with the easiest question. What is this figure? Keep answering, and so that we can discuss, further, and we can be fast in this class along with guiding you with the answers. Obviously, we have the answer slides as well available. So the first question is, what is this figure? And I'm waiting for my children to answer. All the students who always answer, the others should also join in. Okay, so yeah, so what is this figure? What according to you is this figure? Yes, it's basically a hierarchy of evidence is what I call. Okay, this will be the apt answer for this. It's hierarchy of evidence. And who is not able to see the picture? Deepa, how come others are seeing and you're not able to see? I hope everybody can see my my slides, okay? Because then answers won't have come. If there's anybody, Jitu, can you please help this girl, Deepa, please? In she should be able to see the picture. She should be able to see the slide. All right. Now, what do you think? Why and how is it going up? This is a hierarchy of evidence. You see everything down below. Okay, they are those not very powerful studies. When I say not very powerful studies, I mean that the lack of bias, the proper bias is not there. That means there is a lot of error in these down studies. As you go up, the bias decreases. Okay, the confounding factors bias decreases, and that is why the hierarchy is very high in the third three and low in editorials and expert opinions. So here down below in the base of the pyramid, you will see that you have not very powerful studies. These studies, on the other hand, 2, 3, they are very, very powerful studies in the sense that they have lack of, very, very low bias, very, very low, confounding factors. Everything has been taken care of. Meticulous, preparation is there. Proper questioning, proper reasoning. Everything is very, very high. Specificity, sensitivity of the test, and the tests used are very, very, high, and they're getting almost equivalent results with multiple studies. So this is the hierarchy of evidence. And 1, 2, and 3, which is why I have got this for you, so that now fill in the blanks. It starts with expert opinion. Just imagine if I have studied a lot of books, I've seen a lot of cases, my opinion will be expert opinion. Is this sufficient enough for you to decide for your patient? No. Mine is just an opinion. But then come certain case series, case reports, okay, together. I did a case, maybe aisa hua, that person did a case, the same results were found in that. Does a person give a particular medicine, the same results were found. But very important is the population on which these studies were done. So again, bias, a high amount of bias. Then case control, then cohort studies, and then very high in order are the randomized controlled trials, okay, in which which you see, which you take the population of a particular variety, and then you give them the same medicine, and then you follow them up with the results. All right, so these are randomized control trials, and then final what comes the systemic reviews of all these trials together, the meta-analysis. So that is coming very high in the pyramid, but you are going to stick to what is written there. All right, so you will write down 2 as randomized control trials, RCTs, and number 3 as systemic reviews, which is formulated on the basis of these studies. All right, next question. So be quick in answering, guys. Identify the specimen. I do not expect my intelligent students to take. Very good, Asha. Very good. I'm so proud of you. Come on now. Let's identify the specimens. It's not very difficult to. And remember, guys, you do not have to write down very long answers. Why this is a world's this thing look, and the bundles of muscles that are arranged in a wall-like pattern, onion peel appearance, and then that is why. It's just a 1-mark question. Just identify the specimen. No one is asking you why did you write down. If you've written, you'll not get extra marks also. And if you've not written this thing, the specimen's name, your 1 mark is going anyways. Correct? So yeah, this is very easy. Yes, it's a specimen of a hysterectomized uterus, and you have this as the walled appearance, because of which we are now thinking that it's a fibroid uterus. Leiomyoma uteri. Both are correct. Both are going to fetch you marks. What could have been the presenting symptom of this patient? Any 2. So very easy. It's it's almost undergraduate level questions. This is what I'm trying to tell you. This is how the OSCE comes. So yes, very good, Deepa. It's heavy menstrual bleeding and pressure symptoms. Even I have written the same. There are 2. The presenting symptoms usually are either pressure effects or heavy menstrual bleeding, HMB, yes. Pain, maybe not, but these 2 are what is expected. Which organ can be affected? Now this mass effect, see, what I have also not answered is what precaution must be taken to protect the organ. Okay, so which organ can be affected by the mass effect? So mostly the answer which I would want to see is bladder. Okay, so if it's growing anteriorly, it's pressing upon the bladder. If it's going posteriorly, it's pressing upon the rectum, which is the bookish answer, but mostly it is the bladder which is affected. Now what will you answer for? What precaution must be taken to protect the organ? Even I did not find any relevance of this question. I did not find what do they mean by precaution to be taken to protect the organ. How can you protect the bladder, or how can you protect the ureter, even if at all? So this question is very ambiguous. I don't know whether they tried to ask this question exactly, or what exactly did they mean by that. Right now, I'm answering for the 4th question. What is the other surgical procedure for this condition in a young female desiring fertility, which is very. So diagnostic cystoscopy, beta. What will you get out of the diagnostic cystoscopy? It's not a precaution. Maybe ureter, okay, stenting could be an answer, but protecting the organ in which way? If you're doing a hysterectomy, then that way. If a fibroid is pressing upon bladder, what precaution must be taken to protect the organ while doing the hysterectomy of a fibroid uterus? Is that what you want to say? Maybe yes. Couple of things which are coming in my mind, which they've not formulated the question properly, but maybe when you're doing a hysterectomy in a fibroid uterus, you're mostly concerned about, see, had it been a cervical fibroid, it's pretty much understandable that you're very scared of ureter. In that case, a stenting of the ureter could help. Delineating the ureter while doing the hysterectomy is very important. Direct visualization of the ureter, very important. And cystoscopy after completing the hysterectomy, very important. Because just in case you've nicked the ureter, you will be able to find it out intra-op if you do not see the flush coming from the 2 ureters. That's understandable. So all that teaching of injury to the ureter will help you over here. So cervical fibroid will help. This kind of fibroid is mostly pressing upon the bladder, and when you're delineating, the planes are so beautiful in fibroid, you hardly can injure the bladder. But yes, maybe while you're lifting up the bladder, or while you're going inside the abdomen, maybe. So you have to catheterize the bladder. That could be a precaution. You can fill the methylene blue dye post-op, intra-op, and just see if you've injured the bladder. That could be a couple of precautions. Yes, you can write that. Now, what is the other surgical procedure? Come on, this is very, very simple. I would not go for myolysis, but I will not go for UAE. I will not go for MRGFUs. It's very, very clearly written. I do not know how much in your academic institutes it's been pressed upon, but RCOG guidelines are very clear that if you want a patient for the future fertility, the best option, the best test option is myomectomy. If they keep asking you, and what else, maybe then you might say uterine artery embolization or MRGFUs, whereas there is no such continuous, consistent proof that the UAE is good for patients who are seeking fertility. Okay, it is in fact the contrary, that those patients who are looking for fertility, future fertility, they should be discouraged to have MRGFUS or UAE because of further concerns into the growing of the fibroid again, or complete problems of discharge, pain, and regrowing of the fibroids mostly. Plus the query, the integrity of the myometrium after UAE, which might render the uterus very, very prone to rupture during the pregnancy. So these were a couple of things which I've written down over here. So this is Leiomyoma uteri, heavy bleeding pressure symptoms, bladder, rectum would be the organs to look forward to. And like you all said, as far as precautions are concerned, how will you help? So that means probably they're talking about intra-op while you're doing hysterectomy for a fibroid uterus. How will you, protect bladder, ureter? So we've already spoken about it in length. Myomectomy would be the choicest surgery. Remember this always. Okay, whenever there's a question asked for surgical procedure, mostly UAE, MRGFUS, they are non-surgical procedures. Okay, or minimally invasive procedures, right? So surgical procedure for a young female desiring fertility has to be myomectomy and nothing else. There's no doubt about it. All right, now come on, what is the pathology marked by the red arrow? All right. This is the next question. Question number 2's answer will be press. Question number 1, what is it going to be? What is the pathology marked by red arrow? What do you think it is? This is okay, fine. I give it to you. The second question, I give it to you, that what is press, but what is the first question's answer? What is the pathology? Yes, that's right. It's intracranial bleed. This is how it looks like. Okay, intracranial bleed. This is the how. See, if you now, my one very important thing which I want to tell you right now is that at the question, sometimes it happens that looking at you just start reading the questions and you don't listen to this clinical scenario. Okay, that's even me. I see the jump on the question, but if you're not able to understand, sometimes just read the clinical scenario. It will give you the hint. Okay, just be confident when I'll give you a small session right before your practical exams, guys, but you have to be confident in your exams. That confidence comes with a lot of practice, I agree, but it also comes with the right frame of mind. So please, if you're not getting any hint from here, just read the case. So it's an MRI for primary gravida, 34 weeks of gestation, presented with a history of 4 episodes of convulsions. Okay, now you're already thinking on grounds of either epilepsy or eclampsia, right? On examination, she was found to be unconscious and her blood pressure was 180/110. So mostly whenever this posterior thing is shown to you, you already know it is press. And more so when you're talking about 180/110 BP with convulsions, you're now sure that it is most probably press, and this is what the answer is going to be. So the pathology is intracranial bleed, the diagnosis is press, and name 2 newer biomarkers. I want to know 2 newer biomarkers which may help in the prediction of this condition. This I would want to see. Okay, I agree with Neelam also. See, T1W, don't use these terms. At this point, even I find it difficult to remember T1 weighted, T2 weighted images. Do not use these terms, okay? There's nobody's going to, pull your head for this, that why did you not write all this? Just simply write what has been asked and you'll fetch marks. 1 mark is what they want. 1 mark means 1 word, all right? Yeah, so I'm not getting the answer. Biomarkers, I have taught you guys, all right? So I am expecting good answers for this question. See, they've written newer biomarkers. Okay, and biomarkers means what? Yes, here SFLT is going to come. Yes, placental growth factor is going to come. And the ratio between SFLT1 and placental growth factor is going to come. So remember, the placental growth factor means placenta is growing. And what happens in preeclampsia? Placenta is not growing properly. So placental growth factor is decreased in preeclampsia. It is a very important marker of preeclampsia, and preeclampsia is one, adverse condition is stress. So this is the reason why you have placental growth factor and SFLT are very important newer biomarkers for describing whether this patient is going towards adverse preeclampsia, is going to develop preeclampsia or not. That is the idea. If you remember, I've given a proper, definite difference between somebody. I think Nikhil was asking me or somebody, what is the difference between and why do we use and when do we use this placental growth factor, and the other important biofactor, which was a difference between, one was whether adverse effects of preeclampsia are going to come within the next 1 week. And the first one was whether she's going to develop preeclampsia or not. She's already in gestational hypertension. She's going to develop preeclampsia or not. Remember the full Pies chart, okay? And then this placental growth factor one. So this was one, and one was there in gestational hypertension. Full Pies chart was there for prediction of severity of preeclampsia in the coming next 1 week. Yes. Now, what are the other two systemic complications that can develop in this patient? Well, she's already into preeclampsia, so a lot of adverse effects can happen. Not just visual defects, or she's already having intracranial bleed and convulsions. Definitely acute renal injury. I can take that. Transient vision loss. I will take that. Systemic effects, mostly systemic complications. What do they mean? They mean by mostly the problems which can happen, like pulmonary edema, right? So she's very, very high risk for pulmonary edema. When we talk about preeclampsia's adverse circumstances, do not miss out HELP, DIC, pulmonary edema, very, very favorite of examiners, and renal failure. Yes, renal failure. First of all, the most important, most favorite is pulmonary edema, renal failure. And then all the others like HELP syndrome and AFLP and hypertensive encephalopathy, convulsions, eclampsia, and stuff, so on and so forth. So these are basically the answers which we have already discussed, correct? And now we are going on to the next station, which is this. Now, how many of you attended my class on Mullerian abnormalities? I spoke in detail regarding this newer ASHRAE classification, which they have very specifically asked. All right. So this is a developmental anomaly of which structure leads to this condition. It's, anybody is going to answer this question. Come on. Developmental anomaly of which structure leads to this condition? Yes, the Mullerian duct, guys. Mullerian duct, yes. As simple as that. Parameter is very good. Paramesonephric duct or the Mullerian duct, right? This condition belongs to which class and which subclass? I was wondering, whether they will ask the subclass or not. And even if you do forget writing down, do not be confused about subclass, just write down at least the class. That's what I'm trying to tell you over here, that if have a very peaceful, calm mind when you're doing OSCE. It's a very nerve-wracking process. The slides are changed in a specified amount of time, and you get only some couple of minutes to see the slide and write the answers. But if you are, a little calm, answers are going to come into your mind. Remember, the play is not about writing first. The play is about answering it correctly. So take your time, read the question, and answer accordingly. Go slow, go easy, and you will be able to complete it in time. So now, this condition belongs to which class? Yes, guys. So I have included a slide. Okay, all right. I included a slide here in which I had... all right, when you get the final OSCE PPT, I will include the slide in which the entire ASHRAE classification was there. Jitu, if you're there in the class, can you please just send us this slide over here for ASHRAE or SGA classification, which I had included before. It's not here right now. So in that, there was a sub-classification U4 class, all right? U4, and there was without and with the cavity, correct? So it belongs to the U4A, that is with the cavity. So you see, this is a hemi-uterus, and along with it, there is another rudimentary uterus with the cavity. This is what this ASHRAE classification is. Yes, it's non-communicating horn, but with cavity. That was the thing about ASHRAE classification. Jitu, if you're there, can you please just include the slide over here? Just send the slide to me and I'll put it here. And I'll put it here. Or you can just send the slide on the Telegram channel. I had included it there and was just put it on the channel so that we can discuss it along with this class. Now comes the question of name 2 main complaints with which women presents in the OPD. What will be the most important problems with which this kind of uterus female is going to present to you? Guys, with amazing, but such patients usually do not have infertility. They usually present with recurrent pregnancy, mid-trimester miscarriage. Yes, mostly. What else? Preterm labor, agreed. Malpresentations, agreed. Yes, agreed. Dysmenorrhea, yes, why not? Rudimentary horn, she's having a cavity, she's going to be having endometrium. Yes, she's going to have dysmenorrhea. Yes. Now look at the questions, guys. Name 2 main complaints with which the woman is going to come to you in OPD and 4 obstetric complications. So 4 obstetric complications, where we can talk about preterm labor, repeated miscarriages or mid-trimester losses, malpresentations, and retained period of placenta, cervical insufficiency mostly cervical insufficiency, short uterus, shorter cervix. Okay, they usually come up with cervical insufficiency, and main complaints with which the patient is going to come to you will be cyclical, pain. This is dysmenorrhea, and apart from that, and yeah, you can name one of these conditions there, recurrent mid-trimester miscarriages, that you can include. So here it is. This is a problem with the Mullerian tract. This is U4A, cyclical pain, abdomen. Just read it out, guys. I have included Vactral for you. Why? Because every time I was searching for an answer for hemiuterus, I was always getting this Vactral. So just read it out. I'll just include that slide which I want you all to see that slide. Okay, I've sent it. It's there on the channel. It's there on the channel. So I'll just show this to you once. I hope you all can see it. Yeah, this one. I hope everybody can see this. So this is class 0 in which you have a normal uterus. Class 1 where dysmorphic uterus is any dysmorphic uterus. Okay, this is a very beautiful classification because everything earlier which was ambiguous, which had no class, has found a class in this. Okay, so this is ambiguous, any dysmorphic uterus, T-shaped or infantile or any other. Okay, then you have a septate uterus. And just remember one thing, guys. I'm still finding some people, having difficulty in delineating between a septate uterus or a biconvate uterus. There is no doubt, guys. Very important in septate uterus is the outer convexity. Outer convexity remains the same in septate uterus. So this looks like a biconvate uterus, but you have to first and foremost see the outer convexity. So if it is maintained, then it is a partial or a complete septate uterus and not a bicorporeal or a biconvate uterus. Every time there is a dimple here, it dips down, the convexity no more remains. The uterus is now deformed. It's dipping down. That time you can say it's a bicorporeal uterus, whether it is partial, full, whatever it is. Okay, so that is the difference. This is class U3. This is class U2. And now how I remember is U2. Okay, so it is same uterus, but now U2. This is almost looking like 3 uterus. One is 1, 2, 3. That's how I remember it. So it's U3, bicorporeal. It's dipping down, so it's 3 uterus now. 1, 2, 3. And then there is U4, which now you are not going to forget U4 because now it has already come in the examination. It is a hemiuterus. U4 with cavity is A, and without cavity is, but it's not having any cavity inside. There's no endometrium inside, so it is U4B without cavity. And anything else, U5 is aplastic uterus. That means hemiuterus, uterus not completely formed. It's not communicating with the vagina. All these different permutation combinations come under U5. And then you have U6 as well for any unclassified cases. all the cases which are not, finding any root here will be called as U6. Okay. It can happen. It has happened. There are many, many different cases of different kinds of Mullerian abnormalities, but they will all be now included under U6. Earlier, they did not have anything. Now they do have a place to go. Finally, so yeah, I wanted you to read this pattern and I've included it over here. Why? Because every time, like I said, I was searching for hemiuterus, this was cropping up and saying that it always, this factor has an association with the hemiuterus. So this could be a question which can be asked that name an anomaly or a syndrome which is associated with hemiuterus. Yes. So these are the, these obstetrical complications which can happen: fetal growth restriction, malpresentation, preterm birth, and cervical insufficiency, like we have already discussed.